Thank you for that amazing introduction. We're going to try and channel energy of 100 here as we talk with everybody today about RSV in schools and childcare settings. And it's really great to see participants from across the country, from educational settings, community health workers, all sorts of different folks joining into this conversation today. You guys are on the front lines, and we look forward to the discussion as much as anything, because it's always so helpful to hear from you about your approach to all of this as well. But let us get started with just first, a couple of disclosures. So I disclose research grants to my institution of Johns Hopkins, from AstraZeneca, from CDC, Merck, and Pfizer, and Dr. Burrage didn't have any disclosures to make. Our objectives today are to go over the signs and symptoms of RSV, which most of us are familiar with as a common cold, but to talk about how it spreads, to specifically look at the rates of disease in Native American children, talk about prevention products that are in the pipeline, and then talk about RSV in the school and childcare setting, thinking about when children should stay home and what preventive measures schools can take to protect students. So RSV, or respiratory syncytial virus, which is pictured there in the top right picture, is a respiratory virus that infects the lungs and infects our breathing passages. In most adults, I actually probably have RSV right now. I have a little bit of a cold. In most of adults, it causes mild cold-like symptoms, runny nose, can cause a cough. And younger children, you can sometimes see it cause trouble breathing as well, that can result in infants and even young children having to be hospitalized because of RSV. In fact, it is the #1 cause of hospitalizations in babies less than a year of life in the United States. And we know from research that's been done in the Navajo Nation that up to 1 in 15 Navajo infants is hospitalized every year with RSV. So this is definitely something that can really affect Native children. I've seen a comment in the chat that people are not seeing the slides. So I just want to make sure that slides are being seen. Okay, so thank you.
You're in presentation mode. You are in presentation mode.
Great. So you can see the correct slides.
Yes, ma'am.
Okay, super. So there was just a couple comments that weren't being seen, but hopefully that's others, it sounds like, can see it. So another fact about RSV is that nearly 100% of children, so everyone, will have an RSV infection before their second birthday. Babies who are less than 6 months of age are those who are most susceptible to severe RSV. And that's who we're really worried about, in terms of hospitalizations. But even older infants into toddlerhood can sometimes end up hospitalized with RSV. This is, as you can imagine, something that's quite highly contagious. It's spread by respiratory droplets. So even when we speak, but especially when we sneeze or we cough, if we blow our nose and have the droplets on our hands and then touch a doorknob or touch a pencil, that is the most common way that this virus is spread, through those respiratory droplets. RSV can, as I mentioned, be severe. People may have heard of the term bronchiolitis, which is what we talk about when young infants get infected with RSV. You can see an X-ray on the right-hand side, and you can see the ribs, which are showing up as white. The lung tissue, which is the lungs should be filled with air and should be black on the X-ray image, but you can see a lot of white where the arrows are pointing to, which is just that inflammation and infection, where RSV is causing inflammation in those airways, and lots of buildup of mucus, which can sort of block the airways and cause children to have low oxygenation and to become quite sick. We can also see children developing RSV pneumonia, or even sometimes a secondary bacterial pneumonia. So they can get sick with a viral infection. That viral infection can sort of wear down their immune system, break down their mucosal membranes in the back of their nose and their throat, and allow bacteria to invade and cause bacterial pneumonia. So this is something that can produce severe disease. In addition, some kids will actually go on to develop wheezing or even asthma after an RSV infection in infancy. So this is definitely something that, you know, we really try to avoid and try to prevent as much as possible. Even though for a lot of kids, especially toddlers and older kids, this does just sort of come as a common cold. It can cause these more severe forms of disease and long-term effects, especially when we see RSV infections in infants. In the United States, RSV among children under 5 years of age is associated with a variety of different outcomes. We can see here that there are actually 100 to 300 deaths in children from RSV every year. 58,000 to 80,000 hospitalizations, around 520,000 emergency department visits, and 1.5 million outpatient visits. So this is something that definitely places a high burden on our healthcare settings, but just also causes a lot of disease as we're thinking about, you know, all of these kids and even adults and elders who may get sick from RSV. But here specifically, just looking at kids under 5, you know, a lot of burden on the healthcare system, a lot of disease in young kids. When we look at the rates of hospitalization for the United States, this slide shows the hospitalization rate here on the y-axis and then different age groups here on the x-axis, and it compares 2 different time periods, 2000 to 2004, and then the more recent time period of 2016 to 2020. Not a huge difference between those 2 time periods, but the one thing you can really see here is that the highest rates of hospitalization are in the youngest infants, 0 to 5 months of age, and then that sort of goes down. The chances of hospitalization go down gradually as children get older. And you can see in the toddler age group, much lower likelihood of hospitalization, although we still do see toddlers even being hospitalized with RSV. Overall, in the United States, you can see that the rate of hospitalization in children under 5 years of age, here on the far right-hand side of this figure, is under 5 per 1,000. And I'm going to contrast that with some data that we have from the Navajo Nation, the White Mountain Apache tribal lands, Alaska Native communities in Western Alaska and in Anchorage, where from a research study that's been approved through IRBs that found that the rates of disease in Native American children in these study settings is substantially higher than what we see in the new vaccine surveillance network, which is this bar here in black, which is the CDC's surveillance system in 7 different communities around the United States. So again, looking here at hospitalization rates on the y-axis per 1,000, and age group here on the x-axis. And if we take just as an example, the 0 to 2 month olds, I'm going to focus in first on this bar in black, which is the CDC or New Vaccine Surveillance Network data from the general United States population. And then in the gray bar are the data from Anchorage, from Alaska Natives living in Anchorage, you know, a more urban setting. And you can see in all of these different age groups that the rates of disease in urban Alaska Natives is about twice what it is in the general United States population. But then when we look in more rural Alaska Native communities, Western Alaska, the Yukon-Kuskokwim region, which is this gold bar, White River in Arizona, with the White Mountain Apache tribal lands here in the red bar, or the turquoise bar here, data from Chinle on the Navajo Nation, you can see that the rates of disease are quite a bit higher than what we would see in urban Alaska Natives, and quite a bit higher than what we would see in the NVSN or the general CDC data, such that the overall rates of disease in Indigenous children in these settings are actually 2 to 10 times higher than what we see in the general population. So this is definitely something that, we see quite a bit more disease. And why is that the case, right? Like, that's a really important question to ask, because understanding why that's the case is the first step in order to be able to prevent and reduce that burden of disease. So we know that children with prematurity and underlying medical conditions are at increased risk of severe RSV, but those things don't occur, any more often in the native population than they do in the general United States population. These are not the reasons for the disparities, although they are definitely risk factors for RSV. But we've seen in a number of studies that are, help to explain sort of the disparities between Native Americans and white Americans, is that we have higher household crowding, higher number of young children in the household, potentially more smoke exposure from tobacco smoke or from indoor air pollution. And I've shown a picture there on the right. Sometimes, especially in rural settings, we'll see, households that have broken down indoor or wood stoves that can contribute to indoor air pollution. That indoor air pollution or tobacco smoke exposure really irritates the mucous membranes, makes that more susceptible to respiratory viruses. We also see that communities where there's a lack of running water and households where there's a lack of running water, that places infants at risk for severe RSV. Babies who are non-breastfed are also at increased risk for RSV. And poverty is a factor that sort of underlies a number of these conditions. And really, I think the key message here is that the disparities in the burden of RSV disease are really driven by disparities in underlying socioeconomic determinants of health. So when we think about ways to prevent or reduce the burden of RSV, there are definitely some of these things on this list that are really amenable to intervention. Certainly addressing poverty is a key concern and a key goal, but even on a smaller and more tangible level, we can work to make sure that families know the risks of indoor air pollution, know the risks of tobacco smoke exposure, and work to support smoking cessation programs, and include that in our education when we're talking to parents of young infants. We can help to support promotion of access to running water and increased access to running water, and even in households where they're relying on these sorts of water buffaloes in the community, or they have to go out and collect water and bring that back in, really emphasizing the importance of good hand washing, especially if anybody in the household is sick, and really encouraging breastfeeding. We know that that's so helpful for infants and good infant health. The other opportunities that are in the pipeline here for prevention of RSV with more of a biomedical focus to deliver antibodies to help prevent RSV disease. And I just want to talk about a couple of these things, since there are some prevention products that are currently available, as well as some that are in the pipeline that should be available very soon. So in addition to reducing some of those risk factors that we were talking about for RSV, we can also look at ways to passively or actively increase the RSV antibodies that can help prevent infection. So passive means that we're directly delivering antibodies to the infant. And this can be done a couple of different ways. We can do that through injection directly of the antibodies, or we can vaccinate moms. And the moms, while they're pregnant, moms can develop antibodies, pass them across the placenta, and those can help to protect babies. This protection that's passive tends to be more short-lived. It can last up to 6 months or so. And so this is really ideal for young infants with immature immune systems. We know that, we don't get a very good immune response if we vaccinate young babies like 2 weeks old, 3 weeks old. Even when 2 months old, they're just starting to get a good immune response. But we know that the babies are really at the highest risk in those early months. So passive approaches where we can directly get antibodies to babies are a good approach to protecting youngest infants. And then contrasting that with active approaches, such as vaccines, to stimulate the production of protective antibodies. This provides much more durable and long-lasting protection. You can think about this sort of like, the Tdap vaccines that we get that can provide us, with more long-lasting protection. We have to get boosters every once in a while, but much more durable protection. And these would be ideal for children and adults and elders who have good immune systems to respond to those vaccines. So those two different categories of protection that can be available for biomedical interventions. And I mentioned this one over here on the left, maternal immunization. So this really relies on moms coming in. We do this for flu and for pertussis right now. We ask moms to come in while they're pregnant and to get flu and pertussis vaccines, because then they can make antibodies, pass those antibodies across the placenta. And then when the baby's born with that protection already on board to protect them against those diseases. So we don't currently have a maternal RSV vaccine, but we have really promising data for maternal RSV vaccines that have just been found to provide up to 80% protection for infants during the first few months of life. So this is something that's expected to be reviewed by the FDA and may even be licensed and recommended for use later this year. So something in the pipeline. Monoclonal antibodies are also a way that we can deliver antibodies. We heard a lot about monoclonal antibodies during COVID because people with COVID could go in and get monoclonal antibody therapy. We've actually had monoclonal antibodies for RSV for a long time. The picture there on here in the green vial is a monoclonal antibody that's called Syncytial. And it's been licensed and recommended for use for a small subset of infants who are at highest risk of severe RSV. So there are babies, across the country every year who either because they have an underlying heart condition or underlying lung condition, or they're extremely premature, may get doses of Syncytial. These are given as 5 monthly injections and provide good protection against RSV through the RSV season. This other product here called Beyfortus is one that's currently undergoing study. It's been licensed in the European Union, but not yet in the United States. And it was actually developed to protect healthy term infants, so it would be much more broadly available to babies, and to provide that protection for an entire RSV season with just one dose. So we're looking forward to this, the data for this being reviewed by the FDA later this year, and potentially see that available for use by the next RSV season. But we'll have to stay tuned to see if that's going to become available or not. And then the third approach that I mentioned, that active protection through immunization. For kids, those products are still in development and a few years out. There are actually products for elders that you may see come online to protect our elders from RSV infection, potentially later this year even. But for pediatric vaccines, that's still a little while out. So with that, I'm going to pass over to Dr. Burrage, who's going to shift us now to talking about RSV in schools and in childcare settings.
Great. Thank you, Dr. Hammitt, and thank you everyone for joining. So I am Amanda Burrage. I'm a pediatrician and I'm here in Tuba City. So we're going to talk about some of the considerations for schools and childcare centers. I'm really excited to see so many people on this call. It sounds like there's some daycare people. I'm guessing there's some school people, probably even older kids. And so hopefully this will be relevant to all of your settings, but definitely, as mentioned before, please put questions in the chat and we'll definitely come back to them. So what does RSV look like? So you guys are probably familiar with a little bit of RSV, but how do we know it's RSV? How do we know it's not something else? In general, RSV looks like the common cold for most kids and adults. So things that we see with most common colds are runny nose, coughing, sneezing, fevers, may have wheezing, maybe eating a little bit less than normal or be irritable or fussy. So this sounds like every cold we've all, ever seen. And so it's really impossible to tell just by looking at a child whether they have RSV or whether they have a different common cold virus or whether it could be COVID or flu. And so in particular, like specific to RSV, testing is not required because it doesn't change the treatment. And we'll talk a little bit about the home care that is available for helping RSV symptoms. If there are concerns about COVID or flu, I think home tested for COVID or doing some sort of COVID testing, making sure it's not COVID is still really important. And flu, if tested in the first 48 hours of illness, they may be eligible for a medication that could help shorten the duration of flu symptoms. But for RSV in particular, testing doesn't change the management of the illness. So again, it's impossible to tell just by looking at somebody whether the cough is from COVID, from RSV, or from flu. And we'll sort of go into, if we did know it's RSV or if it's one of the, many other common cold viruses that we don't necessarily talk about as much in terms of by name, but there are, many, many others that are causing colds, especially right now in our communities. Next slide, please. So what is the care for RSV? So what we call is supportive care. It's sort of what we can do at home to help kids and adults feel better when you feel sick. So resting is really important, staying hydrated. And for little kids that are still in diapers, you want to sort of monitor for regular wet diapers. For older kids, making sure that they're still urinating, going to the bathroom frequently. We can offer over-the-counter pain or fever medications like Tylenol or ibuprofen if the child has pain or fever. In terms of coughing, there's a really common, how do I make this cough go away? So things that can help with cough is a humidifier. So having a humidifier in the room while they're sleeping can help. And if the child is over 1 year old, a teaspoon of honey can help suppress the cough. I think we all know that if you go to a pharmacy, there's, many, many products to help cough in kids. Check with a provider before you offer those. Many of them are expensive and don't actually really help with the cough. So humidifier and honey, if they're over 1 year old, can be helpful. And then because RSV is caused by a virus, antibiotics don't help. So antibiotics treat bacteria. So unless they have a pneumonia that's sort of downstream from their initial RSV infection, antibiotics don't make RSV better. But thankfully for most kids and adults, symptoms should improve within a week and maybe even starting feeling better sooner. Next slide. So as mentioned before, RSV can be more serious for younger babies and for elders. We are seeing this year, I think you're all aware that we've had a lot more RSV cases late in the fall and into this winter. I think, what was mentioned before, that most kids do see RSV in their first 2 years of life. Some kids that are a little bit older didn't see RSV because we were in this COVID pandemic and people were masking and they weren't necessarily being exposed to all the normal viruses. So we have seen many more cases this year and in some older kids. But symptoms that you may see in a child that would be concerning and would be a reason to be seen by a healthcare professional would be if they're having trouble breathing. So in particular, we look for something called retractions, where you can see their ribs really clearly. You can see them sort of sucking in at the top of the neck or even their nostrils flaring. If they're not able to stay hydrated, so if they're not able to drink enough to keep peeing regularly or regularly having those wet diapers. Similarly, if they're not urinating normally, if they're weak or not acting normally or having trouble waking up, those would all be signs that this child could be more sick and should be checked by a doctor or provider. And then as always, if a caregiver is concerned about the child, if there are worsening symptoms, those are always reasons to be seen and be evaluated and have a full exam. Next slide. So in terms of school and childcare centers, what should we do if a child has RSV? When should they stay home? So with RSV, as with most illnesses, staying home for the first 1 to 3 days of symptoms is when they're most contagious. So trying to limit spread by staying home makes sense. As with flu, if a child has a fever, they should be at home. And they should stay home until the fever has been gone for at least 24 hours without fever-reducing medicines. So if the fever, I feel better today and I don't have a fever, I could go back 24 hours from now. So maybe tomorrow, as long as I hadn't had a fever all day today without those medications. And then we know that masking works for all viruses. So it doesn't only stop COVID. Masking can really help decrease the spread of other viruses. And it would be a good idea to consider masking until the symptoms have fully resolved. Next slide. So I'm guessing a lot of these things look familiar. So we're now, I guess, almost 3 years into the COVID pandemic. And so these are all strategies that we've been using to prevent COVID and also work to prevent RSV and, really all other viruses. So avoiding contact with sick people. So if somebody is sick, hopefully they're staying home. Washing hands. So washing hands well with soap and water or with hand sanitizer is really important. As mentioned, RSV is spread by droplet. And so hand washing is even, more important with RSV than potentially with, other COVID or other viruses. Cover coughs and sneezes. So not into the hands, but into the arm. So teaching kids to cough or sneeze into their arm is really important. And then avoiding touching your face with unwashed hands. And then cleaning and disinfecting surfaces. So RSV can spread from touching things. Thankfully, it's less of a concern with COVID, but it can help prevent viruses and RSV in particular by wiping down surfaces and staying home when sick. So as mentioned before, we don't yet have a vaccine for RSV. Hopefully it'll be available for the next RSV season in this coming, next winter. But in the meantime, getting vaccinated for flu and COVID is really important to prevent and decrease the severity of those illnesses as well. Next slide. So during this COVID pandemic, we've talked about other ways to decrease the spread of viruses. So potentially this is familiar to you. So one way is to increase the ventilation and filtration of indoor air. So we can increase ventilation by opening windows and doors. If they're able to be opened, that can help increase the airflow into the room and sort of dilute out any viruses that may be circulating. HEPA filters, I think, are now much more common. I'm guessing many of you in your schools have purchased HEPA filters to help filter the air and keep it as clean and virus-free as possible. And then you may have heard of this picture on the right is called a Corsi-Rosenthal box. So this is a filter that can be easily made with supplies that you can get at your local home store in terms of a box fan and some square filters and duct tape. So this is an option to help filter air that is actually very effective in filtering. And then we've all been familiar with masks. So well-fitting masks still are very effective at preventing viral spread. So with any cold symptoms, or if anyone's been exposed to anybody who's sick, masks really still can be important at preventing spread. And then the best mask possible. So we know that N95s and KN95s have the best filtration and best protection, and so those would be the recommended masks if worn. So we've shared a lot of information this afternoon and want to direct you to other great resources. So the CDC has a whole area on RSV and the link is there. But if you search CDC and RSV, you can find that section. IHS has some great information as well. And then the Johns Hopkins Center for Indigenous Health has a great resource library. A lot of the images that we showed in our slide are available on that website and can be printed and posted and shared with families and staff to help educate them on RSV and how to prevent them RSV and keep themselves healthy. So it looks like, thank you for posting the resources in the chat as well, so you guys can copy those and bookmark them. But we are happy to answer any questions that you may have. And thank you again for joining today.
Okay, so thank you, Dr. Hammitt. Thank you, Amanda, for kicking us off. So do we have any questions up to now for any of our first two presenters? And for those that are on the call, are you all just, before Tracy joins us and starts to talk about what they're doing in their schools, are the best practices that was just covered things that you all are already doing in your school and child cares? And while you think of that, we do have a question in the chat box. How could we address vaccine? How could we address vaccine hesitancy among Native American populations?
Thanks for that question. I can get started and then let Dr. Burrage chime in as well. I think one of the impressive things to me has always been how high vaccine uptake has been in Native American populations. In many places across the country, the vaccine coverage, with IHS or with tribal health centers is actually higher than it is in the surrounding non-Native community. So I think historically that vaccine confidence has really been there, probably somewhat because because we have these disparities in infectious diseases, these are diseases that many people are familiar with. People know what meningitis can do. People know what pneumonia can do. People know what pertussis can do. So I think that there's been, a real strong desire and community collectivism to try and protect not only our most vulnerable infants, but also elders. And that has really led to high vaccine uptake in a lot of communities. Certainly during the course of the pandemic, Native Americans have had one of the best uptakes and one of the most rapid uptakes of the COVID-19 vaccines, but there are definitely people in all of our communities where they don't have that confidence in the vaccines. They either, oftentimes we see, depending on the different demographics, that there are different concerns. So sometimes if we're talking about, young men who may just, not see themselves as at risk of COVID and not see the value of getting it, sometimes there are concerns related to safety or other concerns. So I think really it's trying to, at this point, it is sort of having a conversation with people and figuring out what are their concerns and addressing those in a really respectful way, helping them to understand and acknowledge sort of the pros and cons, and also, using a narrative approach and helping deliver the message in a way that resonates with community members. So unfortunately, there's not sort of a one-size-fits-all approach to addressing vaccine hesitancy, but we do know that providers, and that includes community health representatives, that includes teachers, that includes nurses, that all of those people are really trusted sources of information. And so having that information available that you can answer people's questions, or if not, then also direct them to a trusted source of information. And I don't know, Dr. Burrage, if you have anything that you want to add to that.
I think that was a great summary. I think it's hard. I mean, I think we've all seen that there has been more hesitancy across the board, unfortunately, with some of the regular childhood vaccines as well. But yeah, I agree with everything Dr. Hammitt said in terms of, trying to understand where it's coming from, trying to stick to the science. Obviously, there's a lot of false information out there. So reassuring that it's safe and it's, strongly recommended by pediatricians. And I think that's fairly true across the board. But I agree that it's a problem, and hopefully we can continue to work on that and move forward.
And so our next question, they was kind of similar because it's talking about how infectious, how long a child should stay out. So I would just comprise the question, and you probably going to be able to answer both questions with the same answer. But a question was asked, we serve children 6 weeks to 5 years. So not all can wear a mask. If the cough lingers for a long time, how would you judge when a child should come back? Is it enough to wait 3 days? And the other person had a question about that system onset. How long are children still contagious with RSV during that symptom onset between that 1 and 3 days if they do not have a fever?
I think those are really good questions. It's impossible to know when somebody is no longer infectious. I also think it's important to remember that before COVID, kids had colds in schools all the time. And so, I think we all as educators agree that keeping kids in school as much as possible is really important, and not having them miss, a ton of school for a lingering cough. We know that in many cases, kids can have what's called a post-viral cough, in which they have a cough for many weeks after having a virus, and that's not contagious. But exactly when it goes from being contagious to not contagious, it's really impossible to know. So I think as long as they're having a fever, staying home that 24 hours afterwards, and then being able to come back is important. But, we can't say that it's impossible that they're going to spread the virus in that time period afterwards, but it definitely decreases. And hopefully we'll go back to, kids having some immunity to RSV. And so it's not going to, be as big of a deal. But I think, unfortunately, being a fact of life as a child is having a lot of viruses. And I think being in childcare and in medicine is, also unfortunately exposes us to those viruses as well. Dr. Hammitt, feel free to add.
Yeah, I think the only thing I would add is that it really does sort of underscore the importance of the disinfection processes, because, most likely if the fever's gone away and the symptoms are improving, that the amount of respiratory virus that's being shed is going to be reduced. But it doesn't mean, if somebody's coughing, they're 3 or 4 days in and they're still coughing, they could still be spewing viral droplets, viral particles. And so just making sure that people are doing really good hand washing and wiping down surfaces, with good frequency will help to limit the spread in that situation.
And so, following up on that myth of spread, is there a mutation at play in the current uptick? And if so, is there a historical cycle to these upticks in RSV or other respiratory illnesses that's out right now?
It's a great question. So I think this season has become as a shock, particularly just because we've had very little RSV season or RSV circulating the past couple of years. Again, that's because, as Dr. Burrage mentioned, when we were doing all of the COVID-19 mitigation, wearing masks, social distancing, we didn't see very much circulation of those respiratory viruses such as RSV. So we have a lot this year, which seems extra because of the contrast against the last 2 years. But it's actually, a rate of disease that's fairly similar to what we've seen historically. We do tend to see RSV. There are 2 main types, RSV-A and RSV-B. We do tend to see those cycling every other year. And every once in a while, we'll get a year that has a big uptick. But I think really what's driving the sort of large number of cases this year is not a change in the RSV virus. This isn't something where we've got a mutation that's making it more severe. This is simply a fact that a lot of young children right now haven't been exposed to RSV in the past. And so once RSV comes into a community, everybody's susceptible to it. And so it affects, a lot of people, infects a lot of people. And so we're seeing a large number of cases just because right now, nobody has immunity to it.
Do we have any additional questions? I want to pause and thank Ms. Renee for including that resource about addressing health misinformation when you're having those conversations with parents and patients. Thank you very much for including that. And so if you do have questions, please put them in the chat box. We're just gonna switch gears and allow Miss Tracy to come now and discuss with us about what the Albuquerque, New Mexico schools are currently doing to keep their staff and students safe from infectious diseases such as COVID and RSV right now. And
hi, good afternoon, everybody. Can you hear me?
yes, ma'am, we can
Okay.
hear you. I am putting the spotlight on you now.
Okay,
All right.
thank you. Good
Yes,
afternoon,
ma'am.
everybody. My name is Tracia Jojola. I am an education program administrator. I work with Bureau operated schools within the Bureau of Indian Education. As was shared, I have 7 schools that I oversee 6 of them in New Mexico and 1 in Oklahoma. So thank you for the invite to meet with all of you today and to share some of the things that we're doing at the school level. I wish I could share my screen. Am I able to do that? Okay, well, I'll just read it off to you. So in order to mitigate a lot of the viruses, like from RSV, COVID, and the flu, what we've done is we've created a structure within our Bureau operated schools. Is we have locked entryways for all of our schools now. So this minimizes the number of visitors that come into the school without being monitored. So everyone who comes to the school must be checked at the entry level, at the entry door. And we encourage parents to pre-plan if there's like doctor's appointments or appointments they have to pull their students for. We ask them to just keep their students home so that we minimize the amount of people that come to the school. Another thing is we've implemented touchless fixtures throughout the school, from faucets to hand sanitizer to soap. We encourage all of our students to wash their hands throughout the day. You know, we've made that a common practice within our school system. We also still require students and staff to wear masks while they're in the facility. We make sure that we monitor students as they come to school. You know, if there are symptoms like runny nose, if there is any indications that they're not feeling well, we do ask families to just keep them home. We don't want to have anybody come in who's sick, just so that we keep everyone safe as far as students and staff. We frequently have the vicinity of the schools, within the schools, the buses, they're cleaned frequently after each use, after transporting students in the morning and after school. We have plexiglass installations at the front office, between desks in the classroom. So we put a lot of effort into making sure that our students are safe as they return to school for academics. As far as school protocols, we're not doing this as much now as we were in the beginning, but we have a system in place where temperature checks are taken at the entrance. And we make sure that it's followed by all visitors when it is in place. Right now, we've kind of stepped away from that a little bit, depending on the community. Some schools, they are still doing that. They're adhering to that with every visitor and every student, but some have backed off a little and don't monitor that as closely as we were. Classrooms are all equipped with hand sanitizers, wipes to clean down desks, to clean down frequently used, maybe a mouse for their computers. But each of our students have equipment individually assigned to them, like laptops, like just the materials that they're going to need, pencils, paper, and so forth. So there's not a lot of sharing that happens in our schools. Also, we've structured it to where recesses are not all held at the same time. Classes go in different intervals. Lunches, we make sure that there's not a lot of individuals in the cafeteria at the same time. We've staggered lunches, or we have the older students eat in the classroom and the younger students eat in the cafeteria, just so we can safely spread everybody out. Some other things that we've put in place are, let me think. We do have one residential program located in Oklahoma. And for that, of course, you all know that they live on site. We can't send them home. If they're ill, we keep them here at the school site. So we have identified dormitories specifically for students who are not feeling well or who have tested positive for COVID. And we closely monitor them. There's an Indian Health Service close by so that they work closely with them. They come in, They monitor the well-being of the student. They provide medication when needed, so that system is in place to make sure that they're not spreading COVID if they have that, or they're not spreading the flu or RSV. So a lot of planning has gone into place to make sure that our schools are safe, our students are safe. We continually work with our tribal leaders. So if there's an executive order that's been put in place, we follow that. For instance, like with the CDC, they say that, if they have a COVID positive case, they can stay home for 5 days, then return. But some tribal executive orders indicate that they want them to stay for 10 days at home. So we follow that rather than following CDC. So just some different changes that we have. And one last thing I want to share is that we do have a remote instructional system in place. So if there's ever a time when we need to close our schools down face-to-face and move to remote instruction, we have that in place so that we can do that. Once we see numbers increase, that's when we will make that decision to move remote. So in a nutshell, that's what I have to share about our schools at this moment. And thank you again for allowing me to be here.
Sorry, I was on mute. No, thank you. So I am checking to see any hands up. Did any of this resonate? Are other schools doing this? Or is the information what you were expecting today? If you have any questions, please ask them. Like, she comes with a live experience, y'all. She's in the trenches with you. She's boots on the ground. She's been a principal. She understands how staff operate, how they think. She know the kids. She understands the parents' concerns. So if you have any questions for her, please use this time. If there's questions that you have, if there's something that she said that operated differently, please do share that. And I do see people in the chat box letting me know that they do follow the same procedures for their Head Start program. So yes, so I like to see that. So while I'm checking the chat box to make sure that I hit on all questions, Shannon's question was answered. That comment aligned. All right. So it is that time. I would like everyone to use those reactions. And I don't know if y'all know this, but if your Zoom has not updated, update y'all Zooms, because now we can comment on the comments, y'all. I didn't know that. So definitely that shows some appreciation to our speakers today. We had some amazing presentations. A lot of good information was shared. Right? A lot of good information. The resources that were shared in the PowerPoint, I will make sure that those infographics, such as like the home remedies, is available for easy download when I send out the presentation slides. If there's any questions, if you're from the Albuquerque, New Mexico area, if you have questions, if you want me to share your contact, please let me know and I would do that. If you need funding to purchase these hand sanitizer, if you need the shields that was discussed, how you put up the shields, if there's individual things that we can help you purchase, like hand wipes, right? We don't think about those things. NIHB has the funding to support purchasing large stocks of these supplies, to support the teachers, to support our public health nurses when you're going out doing your mobile clinics. I know in some places it's snowing right now. We can help you all purchase heaters. If you need to look into ventilation, we can help you all look into like getting the resources and also purchasing these things that can help you all. And then we have a question. It's about the cleaning. Curious if steam and high temp cleaning for counters and desks and other doable surfaces can be effective in place of using chemical disinfection cleaning. So I guess that's a question. Mr. Stevens, can I ask if that was a question for Ms. Stacy, or was that just a general question?
General maybe, but I thought about in the childcare and schoolroom settings. I know the big thing that they talk about, everyone talks about now, is that the presence of, they say these endocrine disruptors and the types of chemicals being used. So it's very much like, what are the ingredients and are they safe? A lot of focus on that. And I thought it might be more effective in enhancing the cleaning if it's considered safe and it is less of a chemical application.
Okay, so Ms. Trista, would you like to speak to the Q list, CDC's Q list?
Sorry, I was looking for my mute button. I just put it in. It's not the CDC, it's the EPA. I apologize. I have a cold. My head feels like it has some mint in it. So yeah, there's a list of disinfectants for emerging viral pathogens, and how to choose a product and how to effectively use the disinfectants, and to check if a certain product has EVP claims, as the question was stated. So you might want to check out that list, because that's really going to help. I'm not saying the other things aren't helpful, but I think without the use of the disinfectants listed in the Q list, you're not really going to be getting rid of the virus. I know it's the same. You have to follow the directions too, just so you know. We do this for HAIs, health acquired infections, healthcare, acquired infections. If it says leave leave the product rather on the surface for 2 minutes, you have to follow the directions in order for the disinfection to really work. And perhaps the MDs can, tell me if I'm right or wrong, but that is how I understand it. And I'm a public health nurse.
Yeah, this is Dr. Burrage. I definitely agree with your answer. So I think sticking to lists that have been approved is a really good idea. I think bleach is actually a really inexpensive and very effective chemical against most viruses, and is safe used correctly. And the contact time that you mentioned is important. As you mentioned, of antimicrobial lights or probably UV lights. I know there have been a lot of things that have emerged during the COVID pandemic. I think actually the basic cleaners are probably the best to stick to. In terms of steam and heat, I think at certain temperatures they can kill viruses, but as alluded to, there are some reasons you wouldn't want to do it. Risking burns. There are pathogens that can live in steam and products like that. So I think sticking with the regular cleaners that are on that list is important. And I just also want to mention that I know you guys are all on the front lines with students, with kids. I think it's been a very understatement of the century, stressful 3 years. And I think, it's really hard to be around all these viruses and know that they're all back in the community and not sort of have the panic that came with the COVID pandemic. And so there's all these things that we put into place that, did protect us successfully from COVID. And I also think it's hard to sort of know when to sort of accept that there are these other viruses back, and that kids are going to get sick, and we're probably going to get sick again. And I think, as a parent, I've been sick many times in the past 8 weeks, and I'm sure many of you have as well. But I just want to commend you all for being on the front lines. I think there are a lot of things that we are doing that are keeping us safer when possible, and yet still letting kids be back in school and in daycare centers and learning and being with their peers and being with mentors and teachers. And so I think that is a huge success, and I just want to thank you all for being there, because I think it's hard and I think it's been stressful.
And so with that, I would like for everyone to make sure you give yourself a pat on the back. Thank you for all of the work that you are doing in your communities, in your workplaces, in your spaces. Thank you. We had, again, some amazing information shared, resources shared, and this is work that you all are doing. And NIHB, I thank